With this, I come to the next segment of International Precision Oncology Symposium. The next segment is going to be moderated by good friend, Dr. Nirmal Raut, Senior Consultant, Adult Solid Medical Oncology at Bhaktivedanta Hospital and Research Institute, Mumbai. Nirmal is a precision oncologist with a passion. You see the brilliance in his work that he does, and you will witness it in the tumor board that is going to conduct. When you hear him, you will realize how gifted he is and how committed he is to precision. He's a true follower of the science and also a huge fan of Dr. Karzrock. So without further ado, I would bring in all the panelists for the session, Dr. Ray Karzrock herself, Dr. Kumar Prabhash, who is a world leader and represents India in the world of lung cancer. He's the head of Department Medical Oncology at Tata Memorial Hospital. Dr. Kumar, a hearty welcome to you. Dr. Paul Hoffman, very, very dear friend of Mani's, academic director and lab of clinical and experimental pathology in Nice, France. Please excuse me, the long name I'm not able to read. Dr. Umut Diesel, again, a passionate precision oncologist from Turkey. We all have seen Umut's brilliance time and again, including in our Impact MTB that we host every Tuesday. Dr. Balazs Halmos, my senior and my mentor from Columbia Presbyterian days, Director of Clinical Cancer Genetics and Director of Thoracic Medical Oncology at Montefiore Health System, New York, USA. Thank you all for gracing us with your presence, and the floor is with Nirmal for his molecular tumor board. Thank you.
Nirmal, it's great to meet you. I know you from Twitter.
Yeah, same here. Absolutely.
You look much better than your picture on Twitter. You need a new picture. I thought you were much older.
Oh, okay. No. So just one question, Dr. Raisel. They call you Ray because of your name, or is it because you are a ray of hope for your patients?
No, it's my name. But thank you so much. That was very nice. That was very sweet.
Okay. So it's a pleasure and indeed an honor that I'm moderating these sessions, and words feel short to express my gratitude to Iylon to have such an esteemed panel here. And whatever I know about lung cancer is because of Dr. Kumar Prabhash. I've been trained at Tata Memorial Hospital under Dr. Kumar Prabhash, and I've been learning about lung cancer from Dr. Balazs, Dr. Raisel, and I'm going to use that in this presentation and ask some questions. Some of the questions might not be very pertinent because these are questions from the developing world, but still I would want to ask them and want to know the perspective from their side. So Dr. Shevanti gave an example from the mythology of Eklavya, like he was not with his guru or his mentor, but from a distance, he would Indian mythology, which is Arjuna, who was an archer, and he would look into the water. He would look into the reflection of the bird in the water, and then he would shoot into the eye of the bird. So I feel our medical oncologist is almost like an Arjuna, and he's looking at the NGS reports, which is the water, and he picks out those mutations, and then he shoots the arrows into the eye with the help of these targeted therapy drugs. And so with that, let me start with the presentation with the case. So this is her story. This lady of 64 years young, a never smoker. She was evaluated for cough and dyspnea, and she had a lung mass, which on biopsy showed a lipidic pattern. And this was an adenocarcinoma, which was TTF1 positive. An RT-PCR was done, which showed an EGFR exon 19 deletion positive. And she was started on erlotinib 150 mg per day since April 2019. We also scanned for the CNS, and she had these extensive metastatic nodular lesions in both cerebral and cerebellar hemispheres, but she was not symptomatic for that. So she was not given any CNS directed therapy, and she was started on erlotinib. So I want to ask this question to the panelists, like when you have such a case, a baseline case of lung cancer, and where the clinical profile, is very much suitable for a driver mutation, like a female non-smoker, probably Asian. That was the ISEL study subgroup, which showed that irrespective of the mutation, even the clinical profile, these patients responded well to EGFR TKI. So what do you prefer? Do you go for the single gene testing, go individually test, or do you go for NGS, the massive, a bigger panel, or maybe a smaller panel containing only 8 to 10 genes, which are important in lung and for which we have drugs available to treat? So can I start with Dr. Razel? Dr. Razel, I want to ask you these questions. I mean, what are your thoughts on single gene testing versus NGS?
Who are you asking? Dr.
Yeah, Dr.
Diesel?
Razel. No, Dr. Razel. Dr. Razel.
Okay.
Yeah.
You're asking me, is that right?
Yeah, right, correct.
Okay, I wasn't clear. I thought you said Dr. Diesel. We do NGS on everybody. First of all, if you're going to do single gene testing, you have to do multiple genes. And doing multiple genes, single gene testing is as expensive, maybe even more expensive, but as expensive as NGS. And for us, we want information. It would be the equivalent to telling the pathologist that you can only look at the right upper hand corner of the slide. Don't look at the whole slide. We want the information of the portfolio of alterations because we want to be ready with, we may need to do a combination. In many patients, a lot of patients respond to erlotinib. Not everybody responds to erlotinib. We have to be prepared for what else is there.
Yeah. Can I ask Dr. Kumar Prabhash? Dr. Kumar, how do you approach these patients? What is your preferred way of testing? Dr. Kumar?
So Nirmal, one is, can you hear me, Nirmal?
Yes, sir. Yes.
So one is what I prefer, and second is what is available. So at this moment, I'll prefer what was commented by the previous faculty. No doubt that NGS gives you more comprehensive information, and in one go you get it. You don't have to wait for it one by one, and tissue is optimally utilized. So you utilize tissue and time both better. But in working in an institution at this moment, we end up using the PCR and for EGFR, IHC for ALK, and FISH for ROS1 in the clinic. But having said that, if I see outside, as the NGS cost is coming down, and we know that there are labs which is doing those 10 and 12 genes panel in Indian 15,000 rupees and 20,000 rupees, it looks like it may be cost effective also. So there are many reasons to do NGS rather than single gene testing in lung cancer patients. But because of logistic issue at this moment, FRL can ROS, then we do NGS subsequently to these patients. But yes, I'll prefer doing NGS rather than single gene testing, Nirmal.
Thank you, Dr. Kumar. Dr. Balas, I want to ask you. Sorry if I call you Dr. Steve Martin because that is how I know you more.
Very nice to meet. You're a true magician. Talking about Twitter based on all your interesting cases that you post. So, first of all, thanks for the invite. It's great to be in Mumbai for a moment. Thinking about this case, I think for metastatic non-small cell lung cancer, we've got two priorities. One is to complete biomarker testing. Biomarker testing is really important to provide optimal care to your patient, but also do it in a timely fashion. Many of these patients need to start treatment in a reasonable time frame. We don't have the luxury of weeks and weeks of working through. So I think each institution will have a little bit of a different approach as to how to meet both goals. Complete biomarker testing, but do it in a way that within 2 weeks or so your patient could start treatment. So for some institutions, as much as NGS is fantastic, some integration of single gene testing to quickly, clean out some of the major, molecular findings might be still, relevant. Actually, here at Montefiore in the Bronx, we do that. We run EGFR, ALK, and RAS very quickly. And usually run ctDNA at the same time. So there's an NGS and a single gene panel running together, and send that tissue NGS in the patients where we haven't received enough information. Tissue NGS takes a long time. It takes 3 to 4 weeks, and that's just unacceptable for many patients. So we have to work through, these algorithms, ultimately, getting the immune biomarker and the molecular biomarker panels completed. And the molecular at least needs to include 9 actionable biomarkers with KRAS, G12C inhibitors, coming to market as of last week. Now, what if you found a patient with an EGFR mutation? Is there a point for NGS on top of that? And that's a research question at the moment. So there's more and more data that suggests that patients with co-mutations, whether they're just P53 or another driver, they are rare, but they occur, just like Dr. Kurzrak mentioned. Not everybody responds. There's some primary progressors, and many times they will harbor a second alteration. Does that make sense to complete an NGS panel on these patients? At the moment, we don't know yet. There's definitely research studies. For example, Sloan Kettering has a nice study for P53 retinoblastoma mutated patients to add chemotherapy to an EGFR inhibitor for the potential small cell transformation. So there's definitely a lot of interest research-wise. We don't do it yet as a routine in a patient with a known EGFR mutation, but we'll treat with an EGFR TKI just like you did.
Yeah, right. So yeah, I agree with you. Sometimes the performance status of the patient does not allow you to wait for 3 to 4 weeks. And that is the time maybe we could use a single gene where you could have reports earlier. Next question I would like to ask my friend, Dr. Umar. Dr. Diesel, I want to ask you that when you are ordering for an NGS in any patient, what are the factors that you consider? Do you look at whether it involves DNA, RNA sequencing? You look at the turnaround time, the profile. What are the factors? Like you have a patient in front of you, a lung cancer patient, you want to order an NGS. What does go at the back of your mind? I want to know that.
Yeah, thank you very much. Thank you for having me. And it's a very complicated question because when I choose in the which platform, which kind of sequencing, DNA or RNA, it depends of the patient's status, it depends of the patient's diagnosis and patient's performance status. Also, turnaround time is also very important. It's comprehensive genomic profiling. It's about 2 weeks or 3 weeks turnaround time to, and also I usually choose the first time to advanced disease. When I met the patients, I suggest to them, I have to sequence your tumor with liquid or from tissue, because if we sequence tumors in the early time, we can do more things, and we can patients will be maybe more advantageous if we sequence them early. And turnaround time is also very important.
Dr. Umar, let's say you have a different case. You have a male, 80 years, a smoker, and the histology is saying a sarcomatoid type of carcinoma. So you are looking for a MET exon 14, and there you want RNA sequencing. So would you choose a panel which includes an RNA sequencing, or how does that? Consider that case and tell me how would you choose an NGS panel for that?
Yeah.
80-year-old male with a smoker and sarcomatoid, and do you begin with the end in mind that probably it could be this mutation, and that's why I need to be sure about my RNA sequencing data? So how does that affect?
Yeah, not all tests has an RNA sequencing. In FMI test, they have in DNA sequencing to look fusion test. If you mean fusions and also MET exon MET skipping mutation in FMI test, and then just sequencing DNA, not only to do RNA sequencing. And I usually choose with comprehensive genomic profiling, with usually in doing the DNA sequencing. If they do the RNA sequencing, we can easily find fusions and translocations, and it's very easy to, because, and also MET mutation, MET exon skipping mutation, we have to use RNA sequencing. Yes, you are right.
Yeah.
And,
yes. Yeah. Thank you, Dr. Umad.
Sorry for the interruption, sir. Can you full screen your screen, sir?
Yeah, sorry.
Yeah. Thank you.
So we many times come across this situation where, the medical oncologist is struggling between the radiologist, the pathologist, and the molecular scientist. They want more and more tissue. So how many times do you come across a QNS report, quantity not sufficient? And how do you ensure that, we are spending so much of money? So do you do anything before sending, the pre-analytical step? How do you ensure that, the tissue is going to be enough for the NGS testing? Dr. Razel, can I ask you this question? Like, do you take any particular precautions that, there is no garbage in, garbage out happening, so that the tissue, is adequate for the testing and you have a good report, a proper report which can be acted upon? So are there any things that you do in the pre-analytical phase, like before sending the biopsy, or any particular things?
So we rely on our pathologists to send the tissue, and there's no question that tissue has an issue because our experience is it takes about 2 weeks to get it out of the pathology lab. And that really increases the time. So it's not that the NGS of tissue takes longer than NGS of blood, but it's finding the tissue and getting it out of the tissue lab that adds 2 weeks. And as previous speaker said, those 2 weeks are very important. So we rely on our pathologists, and then we use commercial labs. We use Foundation Medicine, Caris, Tempus most commonly, but other labs, NeoGenomics and others are also used. And many of these labs, for example, Foundation Medicine has in-house pathologists that try to ensure the adequacy of the tissue. And our experience is that probably about 5 to 10% of patients have insufficient tissue. So you can look at it the other way, 99 to 95% have sufficient tissue. We also do a liquid biopsy at the same time. We simultaneously do a blood test. So we're going to get some results, either from the blood test or from the tissue. The blood test may come out first, but we try to do both because they're complementary tests.
Okay. Dr. Kumar, how much of QNS do you see? How much of, what is your percentage at your center? Like how many patients do have a quantity not sufficient report?
So I'll talk about lung cancer, Dr. Nirmal, and maybe beyond QNS, to get the tissue first, we have a dedicated intervention radiology department. And in spite of that, in lung cancer, more than 20% of the patient, we don't get adequate tissue to go for molecular testing. And that is in spite of our effort we make of our interaction with our intervention radiology. Subsequently, once we have those tissue, we have almost, again, around 50% plus tissues where it is not sufficient enough to have, I'm not saying those 8 markers, I'm saying having those, those 3-4 essential markers which we talk about where it is not enough. So it remains a challenge now also. As much it is far better than what used to be earlier.
Okay. Yeah. Thank you. So let's go forward with our case. This patient took erlotinib, which was started in April, and this was the scans in May 2019. And as you can see, there is a good response. The patient was responding to erlotinib, and this is also the scans, the MRI of the brain. And so there was also an intracranial response, and patient was not symptomatic at baseline, and that's why we did not add any CNS directed therapy. and the patient continued on erlotinib. Patient had some acneiform rash and loose motions, so the dose of erlotinib was reduced to 100 mg. And when a scan was repeated in Jan of 2020, there was some disease progression in the scans, routine follow-up scans. The patient was asymptomatic, so we thought that let's continue with the erlotinib. And in June of 2020, so Jan, there was some asymptomatic progression, but erlotinib continued. So in June of 2020, there was a clear-cut progression which was seen. And as you can see in the scans, as compared to the January scans, the nodular and ground glass consolidation was increased. And so there was a disease progression. And a liquid biopsy was sent at this point of time. And the patient was actually asked that we would like to do a tissue biopsy, but the patient refused. She said she would not do a tissue biopsy. So a liquid biopsy was sent. And in that, we found T790M was negative and exon 19 deletion was also negative. The patient at this point of time was also still not having any symptoms, and that's why she still was continued on erlotinib. And yeah. So this was the local liquid biopsy that was sent, and we thought that probably, the local technology is not enough, and that's why liquid biopsy was sent to Foundation 1. The patient was still not ready for a tissue biopsy. So we repeated a liquid biopsy and sent this time to Foundation 1. And as you can see in this liquid biopsy, we found an EGFR exon 19 deletion, which was also there at the baseline. And there were 3 other mutations which were not significant and which did not influence our decision to treat. So the patient was continued on erlotinib of 150 mg. And in August of 2020, the patient's disease further progressed. And at this point of time, the patient also became symptomatic. She had cough and some dyspnea also could be seen. And and the patient didn't want, so we told the patient that, the mutation report is not picking up anything. And so we would like to put you on chemotherapy. So if you want us to continue on target therapy, we would want to do a tissue biopsy. And at this point of time, the patient agreed, and a new lung biopsy was taken from the progression, from the area of disease progression, and a histopathology confirmed that it is an adenocarcinoma. The tissue was sent to Foundation 1 at this point of time. And so the tissue was sent, and this time we have a different report, and I would discuss the report. Here I would like to ask a question that do we do a tissue biopsy every time that patient does have progression, like you already have a liquid biopsy? So Dr. Paul, I would like to ask you this question. How do you approach a patient of lung cancer who is having progression? How do you test for these mutations? The liquid biopsy is showing just an EGFR exon 19 deletion. So
it's a good question. I will say, first of all, the previous question using NGS versus targeted sequencing, it depends of your organization, of your lab. First of all, it depends also of the reimbursement of the patients. Of course, in the real life, in the best life, if you have a lot of money, you will love to have NGS to do everything for every patient. It depends of the country. It depends of your institutions. So I'm not sure about should we do NGS for everybody? First of all, this is my first question. I didn't have the chance to give any answer before. But of course, if we can do NGS for any patients, of course, is the best choice. Also, it depends of the percentage of tumor cells in your tissue biopsy. Of course, if you have just 5% of tumor cells, your NGS will be false negative. And it's much better to do targeted sequencing at this time. So, okay, NGS versus targeted sequencing, it's a general question. Now, at progression, I will say definitively we need to do liquid biopsy. and to use NGS in liquid biopsy. You can do that in-house. It's not necessary to fund anything to Foundation Medicine, to Guardant Health. You can set up that in your lab, in-house. I mean, now we have a lot of improvement of device, of panels, etc., etc. To send everything to FMI, of course, it's easy, but it's quite expensive. It can take time. So, for example, in my lab, Nice University, France, I mean, we set up everything in my lab, I mean, for doing NGS in liquid biopsy. And for this specific case, I mean, I will do liquid biopsy to see if there is something about MET amplification, for example, to see what's going on in terms of resistant mechanism. And if not, I will try to ask to my physician to do a re-biopsy, a re-tissue biopsy.
Yeah,
because
right.
of course everything is talking about liquid biopsy. Of course, it's fantastic, it's non-invasive, it's okay. But if we can, we should do a re-biopsy in terms of tissue.
Yeah. Thank you, Dr. Paul. Yeah, right. So there is importance of doing biopsy at every progression, because we need to know whether the mutation, the resistance mechanism is on target or off target, and we know that with first generation TKIs, you have more of on target mutations like the T790M, but when you're using osimertinib, then the mechanisms are more of off target ones, and we have bypass pathways which are active, and we need to see that, and for that we need to do a very good NGS. And I give this example to my patients and relatives, and why it is required to do a second biopsy, because applying precision oncology is like playing chess, where one side you have the oncologist and the other side you have the cancer, and the cancer is putting one mutation and the oncologist is putting one drug. And so at every point, the cancer is also smart. It is going to put a different mutation. The oncologist, if he wants to be smart, he has to study the mutation. He cannot play blindly. He needs to know what mutations is going to come. And it's not always going to be T790M. It's only in 50% of the cases. What about the rest of the cases? You will have a MET amplification where where you will have to change the drug, and you will have to combine a capmatinib, a MET inhibitor with that, or it could be a BRAF mutation, which is also common after EGFR TKIs. And for that, you will have to use a BRAF inhibitors. So that's why it's very important to biopsy these patients, because if you want to play smart, like this chess player, then you need to have biopsies at every point, and you need to know what is happening. So this is the Foundation 1 report from the tissue. And as you can see there, we have the EGFR T790M, the subclonal mutation, and there is also a BRAF V600E mutation. There is also a BRAF fusion. The partner here is AGK, the fusion partner. There is an MTAP loss, and there is CDKN2A loss also that is seen here. So Dr. Razel, when you see this kind of a report, where you have multiple mutations, how do you plan the treatment for the patient? Which of the mutations do you want to use the drugs, and how you are going to combine them? You can see here that the EGFR T790, the BRAF, the CDKN2A, for all those we have drugs available. So how are you going to, how does the plan go in your mind for such a patient? Dr. Razel?
Yeah, it's a good point. First of all, I will love to get the turnaround time to get this kind of results first. Is it less than 15 days for FMI or not? First of all, we need to challenge the turnaround time to get all these fantastic results first. This is my first question. So I need to know if I can get these results in less than 15 days or 3 weeks, 1 month, etc., etc.
Can I?
Yeah, Dr. Razel, yes.
So the first thing I want to do is comment on the time. The FMI turns the results around in about 10 or 14 days, but you will not get the results in 10 or 14 days because of what I said before. How long does it take you to get the pathology? So it's 10 or 14 days from the day that they get the pathology. But our experience is that finding the tumor tissue, first of all, it may not be at your institution. If it's at your institution, it's a little easier. And at least in the United States, the pathologists, almost in every institution that we've worked with, take some time before they release the tissue. And that usually adds about 2 weeks to the time.
Yeah, this is good. This
so
is good. This is good. This is good.
Society, we have to deal with that to decrease
This is
that.
good.
Yeah,
this is good. But just to tell you, in my institution now, I used to work with FMI. I have no, but now in my institution, in my lab, I can get this kind of result in 3 days. Okay, not in 14 or 15 days. 3 days.
Yeah.
Okay.
Okay.
So this is the first point. I mean, now we have a kind of acceleration to get the results. Now, of course, if I have a BRAF V60E mutation, of course, I will try to use the association of targeted therapy against BRAF. I mean, because it's quite effective therapy.
Okay. So Dr. Raisel, I want to ask you here that, you have these multiple mutations here. So how do you select your treatment when you see this kind of a report, where there are more than 2 or 3 mutations which can be targeted with drugs? So how do you plan your treatment?
Yeah, so we often bring it to the molecular tumor board, and also we've really had tremendous experience now, really since about 2013, treating thousands of patients essentially, and with combinations. And we also published several papers on how to dose combinations. We did large-scale analysis of 85,000 patients from 3 or 4 papers separately. So the first thing we would target is the EGFR T790M, and we would give osimertinib. And then the next thing, we know that MEK pathway aberrations can cause resistance. So the patient has a V600E, but the patient also has a fusion. And the other thing that we believe, and we've published on this, is that fusions are often very important drivers. The fusions often need a MEK inhibitor. So I know that in the end, this patient got both a BRAF inhibitor and a MEK inhibitor, but we probably would have given osimertinib together with a MEK inhibitor, with trametinib, or it could be another MEK inhibitor. Now, the patient has 2 other, what we consider targetable alterations, and with data that is not as strong as for the first 2. But we would consider targeting these alterations after but giving osimertinib and trametinib would be our first choice. MTAP loss can be associated with pemetrexate sensitivity. So there's papers on that. So that's a possibility as a drug. And CDKN2AB can be associated with it upregulates CDK4/6 and can be associated with palbociclib sensitivity. I know the literature says that it's not, but our data says it is. You can't use the palbociclib as a single agent. It won't work when there's multiple alterations, but if you use it in combinations, we've absolutely seen many responses, and we've actually published on that as well. So the other 2 drug possibilities would be palbociclib and pemetrexate. And by the way, you can't give those 2 together. They're likely to cause problems like myelosuppression. So we would prioritize the osimertinib and the trametinib because that's where we think there's the most data. And then we would keep in our back pocket the possibility of adding either pemetrexate or palbociclib to the combination.
Yeah, I totally agree. What was the NGS? I'm sorry to say that, but what was the NGS results at baseline, at diagnosis? Should we have already the BRAF V60E?
So,
at
Dr.
baseline?
Paul, we did not have a baseline NGS. As you can
Aha.
see, when I presented, we did
Okay.
just a PCR at baseline, and which showed an exon
Okay.
90
Okay.
deletion. And as Dr. Balas mentioned, that when you have a EGFR, do you want to really know the other mutations? But maybe you are right. There was a pre-existing clone which was already there, and when you targeted the EGFR, the pre-existing clone has multiplied.
And it was possible to do immunohistochemistry targeting V60E using the VE1 antibody in the initial biopsy. Is it possible to do that, or you know what I mean?
Yeah, so actually we have not gone back and checked the IHC for BRAF, neither in the earlier sample or in this sample, because the mutation here was very clear with a good allelic frequency.
So from my point of view, I totally agree with my previous speaker. Of course, I will switch with osimertinib.
Okay, so I want to ask Dr. Kumar. Dr. Kumar, when you see any unusual mutations, do you cross-check them with IHC or PCR when you see an NGS report? Do you do a testing again to confirm, whether it's really there, Dr. Kumar?
Dr. Nirmal, yes, sometimes we do it, and that is where we look a bit more information there, because we do have our molecular tumor board, and which we published our last paper that yes, it does make a difference in our decision making, and it appears almost 40% of our patients the tumor board adds value to it. And I agree. And again, more information about what is the allele frequency, it becomes important in many situations when you have those mutations where you are not certain what is the significance. And then our pathologists, they do on some another orthogonal technology to see that what genetic changes we have, it's really there or not. If they're negative, then again there's a question that what you do, that's a separate question. But yes, many times we do it.
Yeah, Dr. Rizal, I wanted to ask you,
but not necessarily always you have those. You need to have those another technology to confirm, or you have to have those tissues to do it. So not always it is possible.
Yeah. Because sometimes when you have a MET amplification, it could be a polysomy 7 which is actually causing the amplification. So you also need to confirm whether the amplification is actually a true amplification, or is it because of the polysomy 7 which is causing that, because that is not going to be targeted with a MET inhibitor. Dr. Rizal, I want to ask you one question here. So if you have a mutation, an acquired resistant mutation, say
Nirmal.
Yes, sir.
So regarding that, yes, we did have a discussion with our molecular biologist and bioinformatics people, and they say they can differentiate that. And if once you have NGS report, they are able to differentiate that polysomy from amplification in NGS. So yes, they said they are able to comment on it. Yeah.
Okay. So you don't need a fish to confirm the copy numbers.
Yes, we did ask this question to them, and they said once you have the value like beyond 6 or 7, then they say that's good enough. And this we have two of our people who are primarily bioinformatics guys, and they do suggested that that's good enough.
Thank you, sir. Dr. Rizal, I wanted to ask you, so if you begin with an EGFR mutation and then the acquired resistance mutation is something like ALK, so the EGFR is not seen now in the NGS report, you are seeing an ALK rearrangement, and now you want to give an ALK inhibitor. So would you still combine the EGFR inhibitor again with the ALK inhibitor, or because that was the primary mutation, like the trunk and branches kind of a concept, or would we just give an ALK inhibitor? I mean, I'm not talking of this case. I'm talking of another case which I had.
And I think you posted on Twitter. So, so what we would do is we would probably combine it, but we also have pretty extensive knowledge of drugs. There's a lot of behind the scenes things that drugs do, and brigatinib is both an EGFR and ALK inhibitor. So it'd be a perfect drug to pick because you get 2 in 1. So it wasn't approved as both. But if you look at the FDA insert, it has a very potent IC50 against both EGFR and ALK. And so it's perfect because there is a subset of lung cancer patients that's been published that have both EGFR and ALK. So that's the drug we would use.
Yes.
Nirmal, can I put a question here, because that was an interesting question from your side. Can you put a question that if you have both of them, ALK and EGFR, then how do we go and which drug to choose out of those available and how safe they are? Because we come across now fairly frequently.
Dr. Razel, the question is to you. So what if there is a coexisting EGFR and ALK?
Can you hear me okay?
Yes. We can hear you.
Upfront, if you.
Yeah, we would give brigatinib because it targets both. And so that's really the way we function, is we look at the targets and we look at, of course, the FDA approval, but just because it's approved for, let's say, ALK or whatever it's approved for, it doesn't mean that drugs don't do anything else. And that's what's very interesting about many of these kinase inhibitors, that they actually do other things. And that can be disadvantaged in that they may have toxicities because they're they have other activities, or you can exploit the other activities. And instead of having to give two different drugs, you can give one drug.
Okay. And Dr. Razel, if we don't have a drug access to brigatinib, would you combine a EGFR and ALK inhibitor?
Yes, we would actually do that. We would do the combination if you don't have access to brigatinib.
Okay. Sorry. Okay. Dr. Balas, you had a comment to make, yeah?
Yes. I was just hoping to chime in, just using your chess analogy that, cancer is not a fair chess player. We just learned about the KRAS G12C inhibitors, and concurrently there was a beautiful publication about acquired resistance. And the patient case who was published on it had 12 different secondary mutations explaining resistance. So it's very hard to catch up, when acquired resistance happens, and it can be very complex. And that's what you see in this case. This patient has at least 3 different subclones: T790M, V600E, and the RAF, kinase fusion driving resistance. I think in this case, it still is appropriate to try to target it, but it also explains why the ctDNA wasn't informative. These subclonal changes, the tip of the iceberg you saw with the exon 19 deletion, but the smaller frequency secondary changes you just couldn't pick up with ctDNA. That just shows you that's the tip of the iceberg issue, with ctDNA. But here, I think, a combination you can try, but it's a phase 1 study that you have to run on your own. It's a combination that just hasn't been really published, tried. So each of us have to think it through, how to provide safety for our patient as you're trying these novel combinations, and starting at the lower dose and very careful monitoring, especially LFTs, etc., is very important.
So can I make a comment about this? Because this is the single most important thing that prevents precision medicine from occurring. And so we've now published, we did it under the auspices of protocol, but we published the iPredict study in Nature Medicine. We published our molecular tumor board in Nature Communications. We've published a way forward where we did individualized combinations for every single patient virtually on the trial. And we show how you can do it safely. There is no other way forward. We cannot do 4.5 million phase 1 studies, and I'm a phase 1 doctor. That is not the way that cannot be the way forward. And then I will tell you one more thing that I learned from a friend, because this was the how started the study. I had a friend that was dying of breast cancer, a physician, And we wanted to give her a combination, but the doctors at her home institution wouldn't do it. And she wrote me an email. Our kids had grown up together. She wrote me an email that changed and was the birth of iPredict. She was on 15 different medicines for all her comorbidities. And remember, she's a physician, but she wasn't an oncologist. So she wasn't mesmerized by our culture. And she said, the email, the title was, "Where is the safety data?" And that day, that changed everything for me, because we give combinations of drugs to every one of our patients. Oncology is the exception to the rule. The average patient walks into your clinic on 8 different drugs, but then you won't give a combination if it's 2 drugs for cancer. But you have no hesitation of giving a heart medication with an antibiotic, with medication for rheumatoid arthritis with antibiotics, with depression medications. You mix them together every day. We all do. We just don't do it for oncology. So the day she sent me that email, that was the day that we started the writing up the iPredict study. So I just wanted to make that comment. She did die, so that was another motivation. But I think it's important to move on from the historical paradigm. And I say that as a phase 1 doctor. I led one of the largest departments in the world for phase 1, but we have to move beyond that.
Yes, just a short question concerning the report of FMI. Do we have any information concerning the TP53 mutation in this case? TP53?
No, we don't have. I mean, that is not seen in the report. We don't have a TP53 in this.
Okay, thank you.
You'll have to give out the mystery of the puzzle, because we have 25 minutes over time. And
sorry.
Chat box has exploded. Your MTB is a hit, and the panelists
Dr. Shevanti, I have noted that. Just one question, Dr. Vaisal. When you combine the 2 drugs, do you always start with a 50% of both and then you go on stepping it up? Like, what is your way of doing combination of therapies?
So again, we wrote a bunch of papers on this that if somebody emails me, I can share the papers. But in general, we start with 50% of the dose of each if there's 2 drugs. And if there's 3 drugs, we start with about 1/3 of the dose of each. But there's also modifications. So antibodies actually combine very nicely. And if we start with an antibody, we will often use the full dose. And the other thing we know is that there's some drug combinations you shouldn't do, like HDAC inhibitors with chemotherapy or PARP inhibitors with chemotherapy, where there's really been a lot of toxicity. And the other place where there's toxicity is if you give 2 drugs that hit the same target, like 2 VEGFR inhibitors. So there's a lot of caveats there, but in general, 2 drugs, 50% of the dose, 3 drugs, 33% of the dose. The doctor sees the patient every week and titrates the dose up to tolerance. We found that to be extraordinarily safe.
Yeah. Yes. Actually, I had presented one case on Twitter, which was an ameloblasttic carcinoma, and you had suggested a combination of lenvatinib and a MEK inhibitor because the patient had an FGFR and KRAS. And let me tell you, I followed your instructions, and the patient is now 1 year plus and doing extremely well. There is a partial response, and I did kind of this titration, and he's almost on half the doses, tramatinib of 1 mg only, and lenvatinib, we could not go more than 10, but there are responses, so it does work. So thank you for that. So I'll just finish this case.
Those are the perfect doses. So congratulations.
Thank you so much. So I'll just finish with this. So the patient was started on osimertinib, 80 mg. BRAF inhibitors were not approved by the insurance. So just osimertinib was started, but then there was progressive disease. In just 1 month, the patient becomes symptomatic. So the patient thought that the patient opted for buying the medicines out of pocket. And so a combination of osimertinib, dabrafenib, and tramatinib was given. And so we talked about the drug-drug interactions and how do we combine. So this is the clinical scale of actionability. And so this is the response. So, we started with the combination. We started with a lower dose, and tried to increase it, but the patient is having response. So as you can see in this lung scans, there is a partial response which you can see. So as of now, the patient is on osimertinib 80 mg, trametinib of 1 mg, and tolerating of 4 tablets of 75 mg of dabrafenib. There are no symptoms because of the disease. There are no side effects. We have come down to these doses, and the performance status of this patient is 0. So the patient has done beautifully well to the combination of an EGFR TKI and a BRAF inhibitor. And so as of now, the patient is responding. When there is a progression, we plan to biopsy and look at the mutational landscape then, and then plan the next treatment. So with that, I would thank all my panelists for your active participation. And I'm sorry, Dr. Shivanti, because of overshooted the time.
Not at all, not at all. It was a wonderful moderation, Nirmal, and a fantastic molecular tumor board. We had total complete fun listening to all the thoughts from everyone, and contradictory thoughts, agreeing thoughts, wonderful different perspectives of into precision oncology. And like I said, the chat box is overflowing with questions. Ray, some of these questions are for you. And so if you have a few minutes, if you could answer them in the chat box, that would really be nice. We would really be grateful. With this, I thank Dr. Razel Kurzrock for her amazing talk and presence, Dr. Nirmal Raut for the amazing moderation.